Hello, and welcome to the Dornsife School of Public Health's 2020 Public Health Immersion program. My name is Caroline Voiles, and I'm the Director of Student Placement and Partnership Development here at Dornsife. I'm joined by Jordan Wood, the Practice Office Assistant and an undergraduate senior at Dornsife. Today, you'll hear from some of our faculty and alumni about how they apply public health research and practice to contributing to the well-being of local, regional, and global communities. Additionally, this module will feature examples of how Dornsife students have the opportunity to apply classroom teaching towards making a difference in the world of public health.
Welcome to Module 1, Mental Health. In this module, you'll hear from Dr. Jonathan Pirtle about his work in the field and MPH alumni Diksha Ramnani about her experience at Dornsife.
Hey everyone, I'm Jonathan Pirtle. I'm an associate professor in the Department of Health Management and Policy. Welcome to Drexel. Welcome to the School of Public Health. I'm glad you have all decided to attend and look forward to meeting all of you in person someday when that time comes. So I'm going to talk about this idea of population mental health and what that means, and provide a brief orientation in this topic. I'm going to share my screen here. Here we go. Okay. So population mental health. So population mental health, I think we can think of it as a kind of a newer term and perhaps a fancy term for this idea of public mental health. And we hear a lot about this these days, and we've heard a lot about this for the past, maybe 5 years or so. But, when you dig back into history, it's interesting that this is not a new idea whatsoever. So I really like this. This is a quote from 1926. Professor Winslow here, who was the president of the American Public Health Association. And it's a long quote, and I just want to read a little bit of it to you. He says, "It is impossible to consider, even in the briefest summary, the future of the program of public health and its movement without at least some reference to the vast and fertile fields of mental hygiene," the language of mental health back then. Today, the attention devoted to this problem by municipal health departments is so slight, but in the not so distant future, I am inclined to believe that the care of mental health will occupy a share of our energies, perhaps as large as that devoted to the whole range of disorders affecting other organs of the body. So Professor Winslow here was way off on his timeline. This has not been the case over the past 100 years or so. Mental health is really addressed by health departments in a public health practice as an exception and by no means the norm. So just a little bit of data from research me and my team have done on this issue of, what are health departments, the government entities responsible for promoting public health, what are they doing to address mental health, if anything? So this is just a simple little graph from a commentary we wrote up in the American Journal of Public Health. And the thing that focuses on is these black lines and how they compare to these gray and white shaded lines. So the black areas, that is a health department doing this thing to address physical health. The gray shaded bars are doing that thing to address violence, and the white bars are doing that thing to address mental health. And as you can see, the proportion of local health departments, LHDs in the US, doing anything prevention related to mental health, engaging in policy making and advocacy related to mental health, and even policy implementation related to the mental health, much, much smaller proportions than for physical health. So really, health departments and the role of health departments in addressing mental health and public health practice, it's really something that's done as an exception, not the norm. These data are from 2016. This is another study we did using data from 2015, so the proportions are a little bit different. But here, the blue lines are the proportion of all local health departments in the US who are performing these activities along the bottom to address mental health. And the gray lines is, the proportion of the US population who lives in a jurisdiction where the local health department is doing that thing. The one I just want to point out here, prevention, mental health stuff is preventable. It can be mitigated, and the proportion of local health departments doing anything in a population-based way to prevent mental illness or its consequences is less than 20%, 16.4% here. So why aren't local health departments doing stuff to address mental health? So informed by these quantitative data, this was by a large survey, we did a qualitative study and did a bunch of interviews with local health department officials to explore this stuff in greater depth. What I want to point out here is these two broad domains of barriers. One, local health department officials said, yes, of course, we think that mental health is part of health. We think it is extremely important. The people in our community come to us and tell us that they want us to address mental health, but we really don't know what to do about it. We also don't have good data, epidemiologic surveillance data about mental health in the populations that we serve. We have limited resources, and we really, again, don't know what to do. They also described, real challenges to partnerships with the local behavioral health entities who were responsible for addressing mental health. The issue there is that the local behavioral health agencies that exist in many jurisdictions, while they are charged with addressing mental health and absolutely do things to address mental health, they really focus on the provision of clinical services to individuals and don't really think about mental health in a population-based approach, don't really think about prevention, and they're really not incentivized to do those things. Their budgets are driven by serving the people who walk in the door. So even if these local behavioral health agencies had a strong desire to, address, think about mental health in a more preventive way, engage in population-based activities, it would be really hard for them to do so within the confines of their budgets. So driven by all this, my colleagues and I, Catherine Nelson, who's a PhD student who works with me in the department, and Michael Udell, who's chair of the Department of Community Health and Prevention, we wrote this paper for the annual review of public health, where we really kind of took a look at what a population-based approach to mental health mean, what are strategies, what are things you can do to address mental health in a population-based way, and what's the evidence for these things? What actually works, given what we know right now? So before I get into that, there's some fundamental things. So what is mental health? Mental health is a construct. It's a social construct, and it's very real, but it's also a construct in the sense of when insurers think about mental health, when psychiatric epidemiologists think about mental health, they're normally thinking over towards the left here. So, a mental health condition and a mental health quote unquote problem being something that meets the full criteria for a specific condition in the diagnostic and statistical manual of the American Psychiatric Association. But that's not it, right? So we also have this construct of psychological distress, and then we have this like doing okay, and then we have flourishing all the way on the other side. So what I really want to convey here is when we think about mental health, it is not a dichotomous thing. It is very, very much along a continuum. And in many ways, that continuum is subjective and is socially constructed. But at the same time, of course, mental distress is very, very real, as we know individually and as we look out in the world around us. So what is population mental health? Here, me and my authors came up with this definition, drawing from definitions of this concept of population health more broadly. We think of it as the distribution and determinants of mental health status among a group of individuals that are defined by a shared geography, socio-demographic characteristics, or source of clinical service utilization. So the key things here are that we're focusing on groups, not individuals, and that we're focusing on policies and big picture structural factors, not just providing services to individuals in clinical office-based settings. So why is a population-based approach to mental health needed? Just a few reasons here. There are many, many, many others. But again, I think it's worth noting that, historically in the United States over the past century, efforts to improve the mental health of the US population has really focused on getting more individual clinical services to individuals, not fostering the conditions that promote positive mental health and prevent mental illness across populations. So it hasn't been addressed in a public health sort of way. It's been addressed in a much more clinical sort of way. And that is suboptimal. So of course, clinical mental health services work for many, many people. They dramatically improve the lives of many people and their families, but it is not a sufficient approach in isolation. One reason for that is there are not nearly enough mental health service providers in the US. So there would need to be about an extra 15,000 psychiatrists and 57,000 psychologists needed by 2025 to address the mental health service demands of the US population. Among people who do receive services, a lot of services that are provided are not evidence-based and or are not effective. They do not work for everyone. And also there is a vast body of evidence telling us that the population burden of mental health problems can be prevented in the first place by reducing exposure to traumatic and chronic stressors over the life course, and especially during key periods of child development. So what can be done in a population-based way to improve the mental health of populations, and who should do those things? What are the tools? So first we have the role of social, economic, and environmental policy interventions. So the what here is public policies, and the who is public policy makers. So these are elected officials at the local, state, and federal level, also appointed and government career policymakers in the executive branch of government. And what they do is also largely driven by what the public wants and what the public demands. So the who here is also the general public and calling on policymakers for these things. But we have a good bit of evidence about policies have the capability to reduce exposure to traumatic stressors and things like adverse childhood experiences that are associated with mental health issues. There's a good bit of research around increased access to green space, reducing exposure to ambient light at night, and also noise at night so people sleep better. There's a good bit of evidence about that in mental health. Reducing financial and housing insecurity, which are sources of major stress for many, far too many people in the United States and other countries as well, of course. And that stress contributes to negative mental health. And reducing structural stigma towards mental illness and other socially marginalized groups. That's another type of stressor that is associated with poor mental health. And policies have the ability to address all of these things, and there's a strong evidence base for all of that. Also the who, so here thinking about the role of health departments. And what can health departments do? They can advocate for the public policies above that would improve population mental health. They can implement communication campaigns to reduce stigma towards people with mental illness and other socially marginalized groups. They can conduct outreach to increase access to community-based mental health services. They can convene stakeholders and coordinate cross-sector partnerships to address mental health. And they can also monitor population mental health status using surveillance and epidemiologic data, and also do things like conduct health impact assessments to inform policy and planning processes. And lastly, healthcare systems as well. So again, thinking about mental health in a population-based way, of course, means going beyond just clinical care. But that said, hospitals and healthcare systems can also do population-based things and launch initiatives that can help in population-based sorts of ways. So they can increase the effectiveness of clinical mental health services, for example, by providing broad-based trainings in providers in evidence-based treatment modalities, such as cognitive behavioral therapies, providing mental health consultation and training to community partners who want to do things to address mental health, employing paraprofessionals to address the social needs of people with mental illness and support recovery, participate in accountable communities for health initiatives, which are really kind of multi-sector collaboratives at a regional level, and also sharing de-identified data with public health practice entities to kind of be an other data source for health departments to keep their finger on the pulse of what's going on with mental health among the population that they serve. So shifting gears a little bit, all of that work I just presented was done pre-COVID, and here we are in this COVID era. And of course, there are tremendous mental health consequences along with social consequences, and these are intertwined to the COVID-19 pandemic. And, physical mortality and morbidity is really the tip of the iceberg when we're thinking about COVID. And I'm sure all of you see and know this as well, just by living through this, just like I am living through this, and the entire public health community and societies are living through this. So just to put, kind of state the obvious in many ways, but kind of unpack it a little bit more about mental health consequences and potential consequences of COVID and who's really at risk, and just ways to think about this. So first, I think we can say that everyone is at risk of mental health consequences related to COVID and its myriad stressors. But to unpack that a little bit more. So we have people who had poor mental health prior to the COVID pandemic beginning. About 19% of the US adult population has a diagnosable mental health condition, and about 5% of the population has a severe and persistent mental health condition. Within that population, we have those who were not receiving mental health care prior to COVID, and then we have those who were. So among this population of people with a diagnosable mental health condition, about a little less than half, 42.6% of them were receiving care. Among the 4.5% of the US population with a severe and persistent mental illness, a larger proportion, about 67% were receiving care. I just put this up there to think about how people have been accessing services or having their services they were accessing pre-COVID interrupted by the pandemic, and how are they accessing care and how are they doing with disruptions in access. Of course, essential workers who face many more stressors than non-essential workers in many ways. We have healthcare workers who were really at the beginning of the pandemic were really kind of the spotlight of the essential workers, and there was a lot written about their mental health and their stressors. But of course, there is everyone else. There are the Uber drivers and the Amazon delivery people and the postal workers and the people in the supermarket and these large proportions of the population who were taking on a good bit of risk to keep working. And there was a lot of stress associated with that. This is just listing some of the quote unquote essential workers and the total number of those workers in the US. People who are financially insecure, which is a large and far too large proportion of the US population at increased risk. We know a lot about financial insecurity being a stressor that contributes to mental health issues. And we can just think of this, prior to COVID, there was a large proportion of the US population who was financially insecure, and that proportion of the population increased after COVID because of COVID, and of course, unemployment, as we all know very well. And lastly, people who are socially stressed because of quarantine. And this can go in both ways, right? A lot of people face social isolation during those early quarantine months, and other people had way too many people around them. They were socially cramped, living in very crowded households. And both of those can be stressful and contribute to mental health issues. Since I created this kind of schema, more and more have been written about mental health and COVID, and there is all of this has been unpacked further, and there is more and more data to kind of untangle all of these things. So lastly, shifting gears, I think I really been thinking about early in COVID, my focus being on population mental health. Obviously, I started thinking with many other people about the mental health effects of COVID. And I just really started thinking about it from an equity perspective. And, not pretty early, there was widespread public recognition, which is wonderful, that the effects of the pandemic were by no means equal. And many, many groups in the US, especially racial and ethnic minorities, lower income groups, were experiencing the brunt of the pandemic worse than others. So I started to think about, okay, we see that. Let's think about the mental health consequences of COVID from an equity perspective. Excuse me, I'm gonna take a sip and I'll share with you some of my thoughts. So how could COVID-19 negatively affect population mental health, and putting this in an equity perspective? And by no means is this exhaustive, the stuff I'm gonna present here, but just some things to think about that seem pretty intuitive and supported by data. So one is grief stemming from COVID-19 mortality. We know that there are these large disparities in COVID-19 mortality, and especially early on, between African Americans and non-Hispanic whites. And we know from the psychiatric epidemiology literature that the sudden death of a loved one is a major stressor, which is a strong risk factor for poor mental health outcomes. There have been some very large and interesting epidemiologic studies where they ask people about all these different traumas and whether or not these things have happened to you. And people say, yes, no, yes, no, yes, no. And then at the end, they ask them, of all these things you said yes to, all these traumas, which one was the worst? And the one people most often rate as the worst was having the sudden and unexpected death of a loved one, which I think is really, really important to keep in mind. So when we see these disparities in COVID-19 mortality, thinking about how those translate into mental health disparities among the loved ones of that person who passed away from COVID. At the time I wrote that paper, I'm not exactly sure what it is now, but I'm sure the disparity probably remains. The COVID-19 mortality rate among Black Americans was 2.6 times higher than that of non-Hispanic whites. Of course, financial stress related to COVID-19, unemployment and lost wages. As I said, financial insecurity is a well-known risk factor for poor mental health. And we know that African Americans and Hispanics were overrepresented in the industries that had the largest share of job losses at the beginning of the pandemic and are also being slow to bounce back. Workers in these industries also had lower than average wages prior to the pandemic. So they were theoretically more financially insecure and then had more layoffs and more reductions in wages. And lastly, social isolation resulting from quarantine. Again, of course, social isolation is a risk factor for poor mental health, but there's a good bit of evidence about the role of audiovisual technologies and Zoom in helping reduce that isolation. But we also know that the digital divide persists. Despite more internet and computers being everywhere and more smartphones, we know that low-income individuals who are disproportionately of color have less access to these technologies. So less access to broadband, slightly less access to smartphones. The smartphone disparity is smaller, but in terms of the amount of data people have, we have these disparities. And streaming video stuff takes up a lot of data. So we have the digital divide persists throughout COVID. So this recently came out, and I'll conclude with this. This is the most recent and best data that we have about the mental health consequences of COVID. So just share a little bit of data from this large population-based survey conducted in the US. So among all respondents who were limited to US adults, as a nationally representative sample, you see these proportions of people experiencing anxiety disorders, depressive disorders, anxiety and depression, specifically COVID-related trauma and stress-related symptoms and disorders, so PTSD symptoms and things like that because of COVID, over a quarter of the population. And we see, much higher rates of people considering suicide, 10% in the past 30 days, and almost half, 40% of the US population is reporting one or more adverse mental health or behavioral symptom due to the post-pandemic. So we see the mental health consequences that we theoretically thought would be there. So this is happening. In the survey, they also stratify the population in many ways, and we also see the disparities that we would expect to see. So these are prevalence rate ratios, which you'll learn about, and what you really just want to look for here as you learn if you don't already know. So for example, this 1.40, that means that Hispanics are 40% more likely than non-Hispanic whites to have symptoms of anxiety disorders or depressive disorders in this post-pandemic sample, COVID era sample. I don't want to say post because it's absolutely not over yet. And the confidence interval here does not go below 1, so we know that it is not significantly significant. But in short, what we see disparities between non-Hispanic whites and Hispanics. Hispanics having higher rates. We see African Americans having higher rates than whites. We see essential workers having higher rates of these mental health issues than non-essential workers. And we also see much higher rates, this is where the magnitude gets the largest, when we look at people who were receiving treatment for mental health issues prior to the pandemic and them now. So what kind of theory suggested would be the case, data indicating actually are the case, and in public health, I think this is going to be a real kind of thrust and push for the discipline of public health to really get into the field of mental health in real and meaningful ways. Because we have these issues here, and in public health, we have the skill set and the tools to think about things in a population-based sort of way and implement population-based sorts of interventions. So thank you. I hope you have a great week here in this practice immersion experience. And again, Jonathan Purtle, Department of Health Management and Policy. Please feel free to shoot me an email if you are interested in any of the stuff and would like to talk more. Thanks so much. Bye-bye.
Next up, we'll hear from Diksha Ramnani.
Hello, I am Diksha Ramnani, and I graduated with my Master's of Public Health and Epidemiology in 2019. Currently, I work at the Wisconsin Department of Health Services in the Division of Public Health, Office of Health Informatics. After graduation, I started as a technical assistant in the state's syndromic surveillance program and transitioned into my current position as the lead data analyst and evaluator in the program. The versatility of the syndromic data allows me to analyze a range of topic areas and apply the data to new and innovative projects and situations. The data is primarily used for surveillance of influenza, drug overdoses, disruptions caused by weather, and other events. Subject matter experts are key partners in defining parameters and inform the breadth of analyses. Analysts from other states and the CDC are also important partners in informing the progression of data collection and quality. This year, the national focus for the use of syndromic surveillance has been on violence and mental health. The definitions that are being currently monitored or are in testing include disaster-related mental health, suicide attempts and ideations, sexual violence, and child abuse and neglect. Trends for these conditions are being evaluated in context of changes in care-seeking behavior and other confounding factors. National partners are also working on definitions for anxiety and depression. My daily work involves being in constant communication with state and national partners, subject matter experts within the department, health professionals, local health officials, and of course the residents of Wisconsin. I often work with my counterparts in other states to develop definitions and create analytical plans. We also collaborate to share data and analyses beyond state borders that support regional and national disease surveillance and overall use of syndromic data. I am grateful to work alongside professionals from all sectors of public health to conduct analyses and inform policy that better serve the public. My depth and ILE experiences at Dornsife were instrumental in helping make the transition to my postgraduate position. I completed my depth experience with a clinical research project with Drexel University's College of Medicine, working with physicians, biomedical engineers, nurses, and patients. Healthcare Improvement Foundation, a nonprofit in Center City, served as my site for ILE experience, where I completed data requests and of course my analytical project. In both experiences, I worked with professionals with very different skill sets than mine, who encouraged collaboration that best served the project and its stakeholders. So my advice to incoming students is to be open to all sorts of opportunities, especially those outside of your comfort zone. Opportunities to work and learn are abundant through Dornsife, through professors, your peers, and the greater Philadelphia community.
This slide highlights one of the recent Dornsife student experiences related to the topic of mental or behavioral health. Recently, a health management and policy major within the MPH program was able to evaluate the effectiveness of mental health interventions within early childhood centers by conducting qualitative interviews with key stakeholders.
The organizations listed here are examples of some other relevant organizations in Philadelphia that have either worked with our students in their internship placements in recent years or who accept volunteers. Opportunities for academic placements may arise closer to spring, but students are encouraged to seek information about these organizations to explore whether their interests align.
Thank you for viewing Module 1 of the 2020 Public Health Immersion program. As a reminder, Dornsife students who complete all 5 online modules and attend at least one of the synchronous sessions are eligible to receive a certificate of completion by completing the relevant evaluations. We welcome your feedback. The rest of these modules can be found on the Immersion program website. Stay tuned for information about the upcoming live virtual sessions that will allow students to explore these topics within the context of community-level disparities. These 3 sessions are population-focused, with panelist faculty on Black health, immigrant health, and LGBT health. We look forward to hearing about your experiences with the Immersion program at Dornsife broadly and as you continue in a career in public health.